So welcome everyone to the final session, and we are so appreciative for your sticking with us in this truly crazy day. Our next speaker is Norm Daniels, who is the Mary B. Saltonstall Professor of Population Health and a Professor of Ethics and Population Health at the Harvard School of Public Health. Norm has produced some of the seminal texts in the field of bioethics, especially the population level, for those of you who are not already familiar with his work. It focuses on questions, many of which he brought up first, regarding the just distribution of health resources, procedurally fair ways to set limits in health resource distribution, and health sector reform at home and abroad, a project that was interestingly developed in part for Seguro Popular. So why don't we turn to our speaker? Thank you, Norm.
Okay, I want to try to cut this into half the time that was allowed, so I'm going to whiz through some of these overheads, and what our plan is to move fairly directly into the panel of the WHO on universal coverage. And so these are some of the things I had hoped to say, but I probably won't get to all of them. That's one way to whiz through this. One issue that in some ways I was asked to talk about was the relationship between social justice, as I understand it, and universal coverage. And there have been allusions to this idea, but the main one that is involved here is the suggestion that there is an important element of standard range of concerns of social justice that focus on a societal obligation to protect opportunity in a society. And then the intuition is that ill health constricts the range of opportunities open to people, either by shortening their lives or by reducing the kinds of things they can do or be in a society. And so if there is a social obligation, and this is a kind of conditional claim, and I borrow justification for the claim that that is not simply from the fact that it's a widely held view in a lot of societies, but also that it's derivable within a range of general theories of social justice. So the claim is that a concern about equality of opportunity or protecting the opportunity range open to individuals has an important implication for access to services. Let me see if I'm going the right, whoops, that's the wrong way. Okay. So one point to make about this approach is that it has a lot of convergence with Marchis' language about capabilities, in that the exercisable opportunities that I'm imagining we protect are a lot, maybe conceptually not indistinct from his notion of capabilities. One implication of this view, it has emerged several different points in this two-day conference, namely that this is a concern about the distribution of health in a population and the promotion of health, not simply health care. Universal coverage is generally focused on health care. So a piece of a social obligation to protect health is to reduce the risks in a population. And that may mean addressing the distribution of the social determinants of health as well as standard public health measures. So we don't simply get at that by treating people who are already ill. Another feature of this view is that you do get an appeal to a notion of a right to health or health care, and it becomes a special case of a right to opportunity or the protection of opportunity. But the specific entitlements that you would get in protecting that might, in my view, has to depend on the fact that there are widespread reasonable disagreements about how to allocate resources and which services to include, and in that context, which shows up even in human rights negotiations about health, one has to rely on a fair process, a deliberative process, to reconcile those disagreements. And that gets us to one source of the disagreements: how much weight to put on financial protection versus health protection in the distribution of services. And here I'm indebted to one of my former students, Brendan Saloner, whose thesis in one paper explores a way to combine a concern about opportunity with financial protection. Which opportunities of people are being protected by the financial protection that people get from not spending their money on health services. And I think this is a very useful way to expand the applicability of this idea. With regard to universal coverage, the main point I'd want to make is however much we could invest in preventing ill health and reducing risks in a society, we're not going to succeed in getting rid of all of that. And therefore, there will be people who get ill and whose opportunities are at risk if we don't do something about it. For example, providing them with access to effective forms of health care. And those have to be what entitlements that gives individuals, what kinds of services or array of services ought to be included in a health system would depend on a lot of factors about those societies, some of which Larry was pointing to when he referred to the social and cultural climate in a particular society, its attitudes towards maybe illness and other things, and risk protection and so on. So I don't have a view that there's any one correct way to do design the array of services that ought to be provided. I've already mentioned the second point, that financial protection is a form of opportunity protection. And several people in the course of this conference have emphasized the importance of fair financing. That is, the progressivity of financing can be measured in the overall composition of the revenue flow into the health sector. And I would want to emphasize the fourth point, which is that sustainability of a system is very important to assuring equity and the preservation of concerns about solidarity in that system. So I think those are important. And one more point, I don't think of efficiency as a non-ethical notion. I think of it as, in this context, very important ethical notion, because with limited resources, how many important health needs you might be able to meet is affected by the efficiency of the system. So I think many moves that are made to promote efficiency should be thought of as aiming at this goal of meeting important health needs as with limited resources. The last point I'd want to emphasize is that there's going to be widespread reasonable disagreement among people about what to cover in a health system and how to trade off the dimensions of the ill-fated cube that we saw in the course of this conference. So there are a number of objections, and I want to very quickly touch on a couple of them. One objection to the idea of providing universal coverage is that we can improve population health and equity more by a fair distribution of the social determinants of health than by assuring equal access to some medical care. with universal coverage. And I would want to emphasize that there's a visible failure in that, in the idea that we don't need anything like universal coverage. A visible failure because we're not attending to the response a lot of people will have that I am in need. I have real claims on health services because the risks have been realized in me, not my neighbors. And what are other people doing to help me? If you say, well, I tried to make the population as healthy as possible, the beneficiaries are not identified people. We don't know who they are. They might simply be lucky individuals who would have in a less risk-reducing society escaped the risk. And I think this is an important political and psychological factor about how what we have to address, because one of the points that emerged in this conference in several different talks was the interaction between a political sphere and what's politically feasible and the ethical analysis of what ought to be done. My own view is that we have to give up on optimal solutions in some cases, where optimal means the very best solution, politics aside. We have to look at the real world of political deliberation, which makes me quite desperate to leave this country. One point that emerged is that universal coverage favors equality over helping the worst off. And it might ignore, as David Guatkin emphasized, the importance of targeted vertical programs that might better reach the worst off. And my view is that there's nothing about universal coverage that excludes targeted programs. The third point, third sort of objection to universal coverage is this misdirection of resources toward medical care and away from more effective ways of improving population health. And this is very important to combine as a concern with the dominant political movement. So you have richer and more powerful people, even in low and middle income countries, who are going to say they want their healthcare system to meet their needs, and they get much more say in that society than others. And that might mean you're going to steer resources away from maybe more effective measures that might be used for the poorer parts of those population into less cost-effective and services that might actually meet the needs of people who've, let's say, gone through an epidemiological transition as opposed to the parts of the population that haven't as successfully. And I don't think that this, I think part of what drives this is the natural political asymmetries in power in many countries. I say natural, I mean regrettable, but that's the way the world is. But I also think part of what drives that is this very widely held view that the people who become sick are, in a certain sense, the identified victims in a society. And this strengthens the appeal of what might otherwise look like a problem only affecting the rich. I mean, this is no longer a rich-poor issue. It becomes a societal question. And I think part of the appeal of that issue is derives from this identified statistical life problem. Well, I won't say anything about this one in the interest of time. The last 2 points I want to make is that I emphasize the fact that there's reasonable disagreement about fair process. And This has shown up in the contrast between medical care and social determinants, between access to health care and financial protection. And I think, as Dan Brock pointed out in one of his questions, there is a fundamental issue about best outcomes versus fair chances, and any cost-effectiveness-based strategy is going to raise that question in a serious way. So I think the disagreement about how much weight to put on one or the other of these goals and how to construe fair chances needs to be addressed through a fair deliberative process. Unfortunately, we don't have a lot of control over the processes that are used, even in rich and developed countries, let alone low-income and middle-income countries. And the last point, and I'll conclude with this, is to emphasize a point that Ali Yemen made, that when we look at a human rights-based approach to health, we encounter a lot of the same problems that I've been focusing on about disagreements. A human rights-based approach doesn't exactly tell us how to prioritize health interventions, even if we have a global recognition that there's a right to health. That may not tell us what entitlements ought to be provided in any particular system. And that's where I think the two approaches can both benefit. Social justice approach and a human rights approach can both benefit from some inclusive process that involves enhanced legitimacy and a buy-in from a larger political process. So why don't I stop with that? And I've tried to summarize a few of the points that emerged, but I do want to express my own appreciation for all the excellent comments and sessions and presentations that people made throughout the 2 days of this. I know as a philosopher, I was particularly attracted to some of the work today, but as somebody in a global health department, I was also very attracted to the content of yesterday. And so maybe for anyone else who has both those hats to wear, this was a good couple days. Thank you.